Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Quality of Life During Treatment with Chemohormonal Therapy, analysis of E3805 chemohormonal androgen ablation randomized trial in prostate cancer, CHAARTED, by Morgans et al. My name is Shabir Alabai, and I am a senior scientist and associate professor at the Princess Margaret Cancer Centre, University Health Network, and the University of Toronto in Toronto, Canada. My oncologic specialties are geriatric oncology and prostate cancer outcomes research. Although prostate cancer is the most common cancer in men and remains one of the top 3 killers in men with cancer, the last decade has seen tremendous progress in its management. Beginning with metastatic, castrate-resistant prostate cancer, docetaxel chemotherapy was approved in 2 pivotal randomized controlled trials in 2004. This was followed by large trials demonstrating survival prolongation and improved disease control with abiraterone, enzalutamide, sipuleucel T, cabazitaxel, and radium-223. Attention then turned to improving outcomes in metastatic castration-sensitive prostate cancer. This refers to a state where the patient has not received medical or surgical therapy to lower androgen levels to castration levels, or their disease is continuing to respond to castration. The mainstay of treatment for metastatic prostate cancer was androgen deprivation therapy for many years, but typically disease progression was noted within 2 to 3 years, along with worsening symptoms. In 2015, Sweeney et al. Published a pivotal randomized controlled trial called CHAARTED of docetaxel in men with metastatic castration-sensitive prostate cancer. Men with metastases and a performance status of 0 to 2 were randomized to androgen deprivation therapy alone or androgen deprivation therapy plus 6 cycles of docetaxel at a dose of 75 milligrams per meter squared. The pivotal trial showed gains in overall survival of 13.6 months, changing the treatment paradigm for this disease. When faced with such a potential game-shifting treatment, it is important to think about 3 dimensions. 1. What is the magnitude of benefit or clinical importance? 2. Do pathophysiologic mechanisms support observations from trials? And 3. What are the side effects and costs? The primary paper in the New England Journal of Medicine described impressive survival gains and improved disease control with docetaxel. Most clinicians would agree that these are important gains. The mechanism of action of docetaxel is well known, and its activity in castration-sensitive disease is credible, given its effects in the castrate-resistant setting. The primary trial also detailed toxicities of docetaxel, measured by clinical investigators using traditional common terminology criteria for adverse events. What was much less clear was the patient experience, which is measured with a variety of patient-reported outcomes and other complementary approaches. These data are particularly important when dealing with treatment for an incurable phase of disease. In the paper accompanying this podcast, Morgans et al. Report on 4 key patient-reported outcomes that were measured as secondary outcomes in the CHAARTED trial. These questionnaires are all well validated, and the areas they assessed are as follows: general and prostate-specific quality of life, fatigue, taxane treatment side effects, and pain intensity and interference with daily function. The authors found that, in general, quality of life as measured by the 4 patient-reported outcomes were similar between men receiving androgen deprivation therapy plus docetaxel compared to androgen deprivation therapy plus placebo. However, prostate cancer-specific quality of life was worse at 3 months, fatigue was worse at 3 months, and taxane-related side effects were worse at all time points in the docetaxel group. Importantly, these differences were generally small, and all were smaller than the minimum clinically important difference. The minimum clinically important difference refers to the minimum change in the outcome that the average patient would notice or consider important. Since differences between docetaxel and placebo were all smaller than the minimum clinically important difference, this suggests that the adverse effects of docetaxel on 4 of the most important areas of quality of life are small and not particularly important for the average patient. At least 2 other factors need to be considered for studies reporting patient-reported outcomes, namely sample size and missing data. As is common for secondary analyses of Phase 3 randomized controlled trials, no formal power calculation was done for the patient-reported outcomes in CHAARTED. However, the actual observed differences between groups for the patient-reported outcomes and the uncertainty around them, measured by the 95% confidence interval, suggested the authors did not miss big detriments to quality of life with treatment. Missing data were larger than 5 to 10%, but generally not particularly high. To their credit, the authors made major efforts to minimize missing data and explored the importance of missing data through appropriate sensitivity analyses. These sensitivity analyses suggested any biases associated with missing data would not likely influence the primary findings and conclusions. So, should everyone with metastatic castration-sensitive prostate cancer receive docetaxel up front? I think it's important to reflect on who is not included in the trial. We already know from other analyses of CHAARTED that the benefit of docetaxel is mainly seen in those with high-volume disease. It is also important to recognize that more frail older men, including those with cognitive or functional limitations or with performance status of 2, were really not included in this trial. Few men age 85 or older were also included. More data are needed for these groups, particularly because multiple studies have shown that they are at higher risk of toxicity and functional decline with chemotherapy. Until such efficacy data are available, if clinicians are thinking of giving docetaxel to more frail older men, a geriatric assessment or formal assessment of chemotherapy toxicity risk with a validated tool, such as the Cancer and Aging Research Group tool or the CRASH tool by Exterman and colleagues, should be used to inform decision-making. Finally, the other big challenge for clinicians seeing men with metastatic castration-sensitive prostate cancer is weighing the pros and cons of docetaxel with androgen receptor axis-targeted agents. In particular, last year, the Latitude trial results were published in which abiraterone and prednisone was compared with placebo in men with metastatic castration-sensitive prostate cancer receiving androgen deprivation therapy. Results demonstrated prolonged overall survival and improved disease control, as well as improvements in quality of life with abiraterone and prednisone. While it is beyond the scope of this podcast to compare and contrast docetaxel with abiraterone, each has pros and cons, and the efficacy and toxicity of both agents will need to be carefully considered when treating metastatic castration-sensitive prostate cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.